Bismillahirrahmanirrahim. Today's lecture is about tumor of the prostate. These are the references for this lecture. During next hour, we will look for the answer to this clinical scenario in which an 81-year-old man present to the clinic complaining of pain with urination. He has had difficulty in starting and stopping the stream of urine for the last 4 months and has recently been suffering from severe back pain. The prostate is a retroperitoneal organ and it encircles the neck of the bladder and urethra. There is no distinct capsule of this organ and it roughly weighs about 20 to 25 gram, while the dimensions of this prostate gland is 4:3:2 centimeters. Anatomically and biologically, this gland is divided into 4 distinct areas such as periurethral zone, transitional zone, central zone and peripheral zone. These areas are distinct as most of the hyperplasia they arise in the transitional zone, while the peripheral zone is the site for most of the carcinomas. The transitional zone comprises about 5% of the prostatic volume, and these are 2 pear-shaped lobes that surround proximal urethra. And here 10% of the prostatic carcinoma can arise. The central zone is about 25% of the prostate volume and it surrounds the transitional zone to angle of the urethra to bladder base. 5% of the cancer can occur in the central zone, while the peripheral zone is about 70% of the prostate volume and it surrounds the central zone, and here more than 80% of the carcinoma arise. This illustration is showing various important structures that are present in this neighborhood. Just memorize this picture and also note that how these conduits carry the urine or semen. This is the gross picture of the normal prostate from a posterior view. Anterior to the rectum and posterior and superior to the prostate are present the paired seminal vesicles that produce about 70% of the secretion of the seminal fluid. The vas deferens from each testes extend to the prostate as well, and seminal vesicle are actually the site for the metastasis from nearby organs. This is the transverse section through a normal prostate which is taken out during autopsy. The central urethra at the depth of the cut is opened anteriorly, and the left, right lateral lobe and the posterior lobes are also seen in this picture, gross picture. The consistency is uniform and this is not showing any nodularity. About 70% of the prostate is composed of peripheral zone, and this is the lateral and posterior lobe, both lateral and posterior lobe. The small anterior zone contain mostly fibromuscular stroma. This is a pelvic CT scan just to show you important relation of the prostate and the area where you will look for the prostate in a CT. The prostate lies below the bladder and the prostatic portion of the urethra traverses the prostate gland. It lies anterior to the rectum. The prostate is composed of glands and stroma. The glands are lined by double layered epithelium, and the basal layer is low cuboidal epithelium, while the luminal side epithelium is columnar or secretory cell epithelium. So this epithelium is undergone in many times into papillary enfolding that is marked by this black arrow. The stroma is abundant and it is fibromuscular. In the transition zone, it contains compact fascicles of smooth muscle, and in central zone the stroma is densest and least dense in the peripheral zone, while in the transitional zone this is in between. There is a little increase in the size of prostate until puberty. At puberty, under the influence of testosterone, growth and differentiation occur. The enzyme 5-alpha reductase in prostate stromal cells convert testosterone that is produced by Leydig cell of the testes into dihydrotestosterone, and this dihydrotestosterone is responsible for prostatic growth. The castration lead to the atrophy of the prostate through apoptosis. This photomicrograph is also showing normal histology of the prostate at higher magnification. The glands are lined by double layered epithelium that have got inner columnar and outer low cuboidal epithelial cells. The intervening stroma is fibromuscular, and there is also a small pink concretion that is typical of corpora myliaceae, and it is present in benign prostatic glands of older men. These epithelial cells, do not normally have prominent nucleoli. The common pathologies in this organ are ectopia, inflammation, calculi, benign nodular enlargement or benign prostatic hyperplasia, and tumors. The benign prostatic hyperplasia is the most common among these, and it is much common that it is considered a normal aging process. This benign prostatic hyperplasia has been described in this video on prostatitis with BPH, and today we are concerned about the tumors of the prostate. On the basis of their clinical presentation, these prostatic tumor can be of 4 types: latent carcinoma, incidental carcinoma, occult carcinoma, and clinical carcinoma. The latent carcinoma is found unexpectedly as a small focus of carcinoma in the prostate during autopsy studies in a man who has died of other cause, and it is present in 25 to 35% of the cases, while incidental carcinoma is revealed in prostatectomies done for benign prostatic hyperplasia, and this is common in 15 to 20% of the cases. Then occult carcinoma is the type of carcinoma in which the patient has no symptom of prostatic carcinoma but show evidence of metastasis on clinical examination and investigation, and it is present in 10% of the scenarios. The clinical carcinoma is the type that is detected by rectal examination and other investigation and confirmed by pathological examination of biopsy of the prostate, and it is present in 30% of the cases. The most common type of the prostatic tumor is adenocarcinoma. So when we talk about prostatic tumor, unless otherwise specified, we mean actually adenocarcinoma. This is the most common form of cancer in men in USA, and about 174,650 cases were recorded in 2019. 29% of the cancers were of this variety in USA in 2007. That means about 1/3 of all cancer cases were of prostate tumor. The incidence of this tumor is decreasing in Western world due to some reasons that we are going to discuss later, and this is now about 20% of all male cancers. Means every 5th case of the cancer is due to prostate tumor. This is the second cause of cancer related death in men. The number one cause of death in men is lung cancer. This tumor was number one in 1990, and it has, due to increased imaging and increased surveillance and increased screening programs of this tumor, this is now decreased. The prostate tumor has got varied biological behavior. There are some tumors such as latent tumor or incidental or occult. They are clinically insignificant, and aggressive tumor also there that have got more mortality. It is a disease of aging, and the mortality is also dropped over last 30 years. So 20% of the cases were in 50s, while 70% of the patients were in their 70s and 80s. This diagram is showing the estimated cancer incidence by site and sex, and it is showing that about 0.9 million of the cases were reported for both in men and women in 2019. And the number one tumor for the male is prostate tumor, which accounts for about 20% of the total number of the cases, while the number two of the cancer was lung and bronchus, that accounted for about 13% of the cases, while number three is the tumor from the colon and rectum, that is about 9% of the total cases. So top three tumors in the male are from prostate, bronchus and lung, and colon and rectum, while for female the breast is number one site, and it accounts for about 1/3 of all of the tumors for female, and number two is lung and bronchus, and number three site is the colon and rectum, which equates the tumor from the uterine corpus, that is also about 7%. This is the estimated cancer death by site and sex in 2019. In the United States, about 318,420 deaths were in men, while in female 282,500 deaths were reported. The major cause of the death in men was the tumor from the lung and bronchus, while the tumor from the prostate and colon and rectum were second and third in that category. The tumors in female, the leading cause of the death was also lung and bronchus, while the second one was breast and third one was the tumor from the pancreas, colon and rectum. All these four sites, they account for about more than 50% of the tumors in female. The leukemias and non-Hodgkin lymphomas, for both of these categories, the death rate is almost equal. This graph is corroborating the statement that we made earlier that the incidence of this prostate cancer is decreasing now. Here you can see that this prostate carcinoma was highest in 90s. There is a peak in this graph in 90s, and then it is being decreased consistently over the last 3 decades. This map is showing the geographic variation in the cancer incidence. The most common tumors of the developed world are CA lung, CA breast, CA prostate, and colorectal carcinoma, while liver, cervical, and esophageal carcinomas are the commonest tumor in the developing world. The blue color is for Europe and China and Russia, and here the commonest variety of the tumor is lung and bronchus tumors, while the magenta color is for subcontinent, and here the oral cavity tumors are the commonest one. The yellow is for Saudi Arabia and some other Arab countries, where colon and rectal carcinomas are commonest. Kaposi sarcoma is a tumor that is associated with HIV infection, and it is common in some African countries. The sea green color, you can see that this greenish color is for prostate, and it is the disease of or a carcinoma of advanced world mostly. The commonest tumor is prostate tumor. The prostate is an organ that is sensitive to androgens. The androgens and androgen receptors are involved in the development, progression, and also in the therapeutics of this tumor. Both inherited genetic factors and environmental factors are linked with etiology of the tumor. It is considered that both these factors play a role simultaneously, as the disease is less common in Japanese, but it is more common in Japanese immigrant in the USA. It is double in African American ethnic group. The genetic factors are responsible for genetic changes in prostate epithelium that predispose it to malignant transformation, either independently or in collaboration with other environmental factors. About 1/10 of the cases have familial tendency, so risk of this prostatic carcinoma is increased in first degree relatives of patients of prostatic carcinoma. So the exposure to carcinogens, estrogen, and oxidants are responsible for cell injury and continuous inflammation that orchestrate the cancer development through genetic and epigenetic changes. In addition to racial and age difference, diet has important role in the etiopathogenesis of the prostate carcinoma. This tumor is more common in USA, South America, Europe, and Australia. The high incidence has been linked to high quantity of charred meat and dietary fats such as alpha-linoleic acid that are the component of Western diet. These are responsible for formation of heterocyclic aromatic amines and polycyclic aromatic hydrocarbon that are carcinogenic, and these are detoxified by glutathione S transferase. This detoxification process is disturbed in polymorphism of gene GSTP1, so it will result in increased chances for progression to cancer development. The protective factors include consumption of isoflavonoid genestin that inhibit 5-alpha reductase enzyme, cruciferous vegetables such as cabbage and broccoli that contains isocyanate sulforaphane, and lycopene that is found in tomatoes, and statin drugs that are the inhibitors of cholesterol biosynthesis. The inherited genetic factors are also linked with pathogenesis of this disease. Men with first degree relatives, they have 2.5-fold risk of prostate cancer. That increases to 5-fold when the first degree relatives are 2 or more. Many germline mutations are linked with prostate carcinoma. One is MYC, There are variants in the regulated region of the MIC that influence its expression, and this is linked with high risk of early onset cancer. And this variety is more aggressive in nature when this mutation is present. Mutation in DNA repair genes have also been linked to this cancer. BRCA2 is responsible for homologous recombination of DNA. Defect in this gene result in defective mechanism and lead to oncogenesis. And DNA mismatch repair gene are also responsible for cancer development as part of Lynch syndrome. The transcription factor HOXB13 is responsible for the development of prostate in embryonic life. A variant of this transcription factor of HOXB13 has also been linked with prostatic cancer. The prostate is an organ that is dependent on androgens, and through androgen receptors the growth and survival of this prostate cancer cell is possible, and if castration is performed it will result in regression of the tumor due to androgen receptor blockade or blockade of androgen or androgen receptor or anywhere in this mechanism, as 90% of the testosterone is secreted from testes and 10% of this testosterone comes from adrenal. But unfortunately most of the tumor they develop mechanism for the against this blockade by the androgen receptor blockade. So there are androgen receptor gene amplification, splice variant that lack the ligand binding domain, mutations in androgen receptor that allow it to be activated by non-androgen ligand, and mutation or epigenetic changes that activate alternative signaling pathway and they bypass the need for androgen receptor. So they do not need androgen receptor anymore. They directly activate the growth and survival of these tumor cells. So these are basic four mechanisms for the development of resistance against the androgen blockade. So another mechanism is the chromosomal rearrangement that is present in about 50% of the cases. This is the juxtaposition of the coding sequence of ETS family transcription factor, and most commonly ERG or ETV1 are involved, and these transcription factor genes are placed next to the androgen regulated TMPRSS gene. Okay, and then due to this juxtaposition, now the ETS oncogene is under control of TMPRSS2 promoter that is androgen regulated, and this overexpression will lead to upregulation of the matrix metalloproteases, and these normal epithelial prostate cells they become more invasive. This molecular change or juxtaposition of the ETS family transcription factor will result in a distinctive morphology and a different gene expression that will result in a specific molecular subclass of the prostate cancer. This entity is or this ETS gene rearrangement is an important one, and it can be used for prostate cancer screening for its early diagnosis, and these ETS fusion genes are also detectable by sensitive PCR assays in urine. The other genetic changes that are linked with this prostatic carcinoma are silencing of gene encoding P27, that is inhibitor of cyclin dependent kinases, or amplification of MYC and deletion of P10 that will result in cell growth and resistance to anti-androgen therapy, or loss of P53 and deletion of RB and amplification of the androgen receptors gene. These three modifications are seen in late stages of the prostatic carcinoma. Now the epigenetic alterations. The epigenetic silencing of GSTP1 is the most common epigenetic alteration. This is a gene for glutathione S transferase that is located on the long arm of chromosome 11 on 13 region, and this is the most important part of carcinogenic damage control pathway because it detoxifies the carcinogen. So when this glutathione S transferase is hypermethylated, it will result in downregulation of GSTP1 expression, and that will result in more predisposition toward cancer development, as this protein is now not going to detoxify the carcinogen. The other epigenetic modifications are cell cycle regulators such as RBCDKN2A and maintenance of genomic stability such as MLH1 and MSH2 and Wnt signaling pathway in which the APC is involved. There are some lesions that are related to prostate carcinoma and harbinger towards stepwise development of the prostatic carcinoma. The malignancies confined to the epithelium are termed as in situ or in situ carcinoma elsewhere in the body, but here in the prostate they are termed as intraepithelial neoplasia. These prostatic intraepithelial neoplasia are termed because their biological behavior is still controversial. There are some evidence that support it being a precursor lesion, that these are predominantly present in the peripheral zone. The prostate that contain cancer have a high frequency of PIN or prostatic intraepithelial neoplasia, and they are more prominently present in the proximity to the cancer, and they have got the molecular changes same with the carcinoma or adenocarcinoma. These are actually intraductal dysplastic epithelium that has proliferated, and these have the tendency to progress to the carcinoma. This is the schema or series of events that lead to the progression of the cancer of the prostate due to certain dietary exposure, inflammation, androgen, or genetic or epigenetic event. The prostatic epithelium is disturbed. There is also the hypermethylation of the GSTP1 promoter or temperous EATS fusion gene formation that will result in PIN or prostatic intraepithelial neoplasia, and after P27 loss there is development or formation of localized prostatic adenocarcinoma. This localized prostatic adenocarcinoma, when there is loss of P10 and activation of the telomerase, will lead to metastasis, and metastasis usually to lymph node and bone, and in later stages when there is mutation in the androgen receptor, P53, RB mutation or MYC amplification, these results in aggressive form of castration resistant cancers or prostatic adenocarcinomas. When term prostate carcinoma is used, it usually refers to the SNR variant of the prostate adenocarcinoma, that is the commonest variety of the tumor. This tumor frequently involves the peripheral zone of the prostate, where its frequency is 70%, but the other areas are not exempted from the tumor. Transitional zone may harbor 5% of the prostate adenocarcinoma, and the central zone is affected in 25% of the cases. When located in the peripheral zone, it can be palpated by digital rectal examination, and the cut surface of the prostate adenocarcinoma is grey-white and firm to palpation, and in this picture it is marked by this red circle, and here the posterior area of the prostate gland is affected, peripheral posterior area in this prostate is involved by this tumor. The non-malignant area of the prostate is spongy in appearance. This is the transverse section of gross specimen of prostate adenocarcinoma that reveals a single prominent nodule and some small dark glandular concretion are also present in the normal adjacent prostate. As compared to the BPH, benign prostatic hyperplasia, this prostate is not significantly enlarged and there is no nodularity as we have seen in the BPH earlier. This is another gross specimen removed through radical prostatectomy, revealing transverse section of prostate gland having irregular yellowish nodule, mostly in the posterior region. It is not necessary that the prostatic adenocarcinoma almost always increases the size of the gland. There may be association of the adenocarcinoma with benign prostatic hyperplasia. So the architecture of these glands in the morphology of the adenocarcinoma are well defined and they have adopted recognizable patterns, and these recognizable patterns are helpful in the grading of these adenocarcinoma, that is termed as Gleason grading, and we will discuss that grading system in detail later. The gland size is smaller than the benign gland and these are crowded, and the lining epithelium of these malignant gland is single uniform layer of cuboidal or low columnar epithelial cells, and the outer basal layer is absent in malignant cell. In this picture on the right, there are two types of the gland. The central one are closely packed and they are composed of numerous small single layered epithelium, while on the extreme right and extreme left there are some glands that are a bit larger and they are lined by double layered epithelium. Then the branching and papillary enfolding that was characteristic of the BPH and that was also present in normal prostate glands is absent in prostatic adenocarcinoma, and this cytoplasm is pale, clear and is amphophilic, means it takes both the dyes, both the eosinophilic and basophilic dyes. The nuclei are enlarged and they contain one or more large nucleoli. The pleomorphism in these adenocarcinoma of the prostate is not marked, and mitotic figures are uncommon. This photomicrograph is showing the histopathology of the malignant glands. Here you can see that the cytoplasm of these malignant glands are amphophilic, and the appearance of the nuclei, they are large and there are prominent nuclei within these nuclei. The pleomorphism is not a prominent feature of this tumor. However, there is some variation in nuclear size and shape. The mitotic figures are also uncommon in this prostatic tumor. This tumor is spread locally or spread through lymphatics, or it may adopt hematogenous route for spread. When locally infiltrating, it involves periprostatic tissue and seminal vesicle are involved in almost all cases. Base of the urinary bladder is affected in later stages when it may result in ureteric obstruction. The lymphatic spread occur through obturator nodes first and finally para-aortic nodes, and The bone metastasis is the site where which is the most common site for its metastasis, and the characteristic lesion in the bone are osteoblastic, and the bones that are involved usually are axial skeleton. The osteoblastic lesions are due to activation of Wnt signaling pathway in the osteoblast. The bones that are affected are lumbar spine, proximal femur, pelvis, thoracic spine and ribs, and viscera are also involved, but exceptionally. This is the sagittal section of vertebral bone at autopsy, and it is showing multiple foci of pale and irregular metastatic tumor. These are osteoblastic in appearance. Virtually all bone metastases occur from carcinomas, and the mnemonic to remember these carcinoma is lead cattle or PBKTL. So these PBKTL stands for prostate, breast, kidney, thyroid and lung. The metastases from other sites are usually these are osteolytic that destroy the bone, and these are radiolucent, while metastases from the prostate cancer are osteoblastic. That means they are associated with new bone formation, and these are radiodense. This radiograph is showing osteoblastic metastasis to the vertebral body, and this is characteristic of prostate metastasis. The diagnostic challenges that are associated with the prostatic adenocarcinoma are a small biopsy sample, the presence of admixed benign and malignant glands in the biopsy tissue, the presence of minimal histological findings that lead to underdiagnosis of the lesion, and mimickers of the cancer that are associated with the misdiagnosis of prostatic carcinoma. The specific findings are perineural invasion, but the tumor is diagnosed on the basis of other morphological findings. Also, one important characteristic is absence of basal layer of the epithelium. So immunohistochemical marker for the basal layer are negative, such as P63. Then alpha methyl acyl CoA racemase is the another useful marker that is upregulated in prostatic carcinoma. Its sensitivity is 82 to 100% in various studies. This AMACR is an enzyme that is involved in the beta oxidation of the branch chain amino acid, and it is selectively upregulated in prostate cancer and its precursor lesion as compared to the normal prostate. The EZH2 or enhancer of ZEAST2 is another marker that is a transcriptional repressor. It downregulates E-cadherin and associated with progression and metastatic of prostatic cancer. This is also overexpressed in lobular carcinoma of the breast and signet ring carcinoma of the stomach. PCA3 is another marker that is upregulated in prostate carcinoma, and this PCA3 gene is located on long arm of chromosome 9, and it encodes a regulatory RNA. The presence of both the benign and malignant glands together is one of the diagnostic challenge in the diagnosis of prostate adenocarcinoma. Here there is presence of two types of glands. One are small, crowded and lined by single layer epithelium, while others, such as on upper left, these are lined by double layered epithelium. These are also irregular, but still the papillary projection is there, and they are lined by double layered epithelium. Down in the right lower side there is also presence of benign glands. So when seen under high power, the picture is more clear. Now in the upper part, this gland lining is a gland lining of a benign gland, the epithelium of a benign gland, lined by double layered epithelium, while these three glands that are present in the lower side, they are lined by, in fact 4 or 5, they are lined by a single layer of epithelium, and this epithelium is not showing much atypia, but this single layered cuboidal, low cuboidal epithelium is showing a large nucleus and a prominent nucleoli. The cytoplasm is amphiphilic. One of the specific findings in the diagnosis of prostatic carcinoma is perineural invasion. This is the whole mount of radical prostatectomy specimen. Here there is a small peripheral lesion, and this peripheral zone lesion is showing an area of perineural invasion. So this is the high power view of from the another case that is showing the perineural invasion that is surrounded by malignant glands. The prostatic intraepithelial neoplasia is present in about 80% of the cases that have been removed for prostatic adenocarcinoma. They are actually present in architecturally benign prostatic acini that are lined by cytologically atypical cell with prominent nucleoli. The cytology of this PIN and carcinoma are identical. All the cytological features are identical, but architecturally the acini of the gland are more toward benign. The PIN involve larger branching gland with papillary enfolding, and this basal layer in this PIN is patchy. It is absent in segments, but the basement membrane is intact. Now question arises why we do not call it carcinoma in situ, why there is another term that is prostatic intraepithelial neoplasia for this entity. The term carcinoma in situ is not used for PIN because of its uncertainty about progression. Both the carcinoma and PIN, they are present in the peripheral zone. The prostate that contain cancer have a higher frequency and a great extent of PIN, and PIN is also seen in closer proximity to the cancer. Many of the molecular changes that are present in the invasive cancer are also present in the prostatic intraepithelial neoplasia. This photomicrograph is from a needle biopsy specimen from prostate tissue showing a high-grade PIN that is marked by this black arrow. The surrounding glands are benign, and these are lined by double-layered epithelium, whereas this double layering is absent in this adenocarcinomatous focus. This is lined by single layer epithelium that is double layered at places. So this is prostatic intraepithelial neoplasia. The immunohistochemical staining for alpha methyl acyl coenzyme A racemase or AMACR is helpful to identify adenocarcinomatous cells that show increased amount of this enzyme. The grading system for prostatic adenocarcinoma is termed. Now this photomicrograph is showing the Gleason pattern 3. or the morphology that is confirming the Gleason grade 3. These glands are single, separate, variable and closely packed, but they are irregularly separated, ragged and poorly defined edge. So these are Gleason grade 3. Then here this morphology is showing the ragged masses of anaplastic carcinoma that is with only enough gland formation or vacuole to identify it as adenocarcinoma. So this is termed as Gleason pattern or grade 5. Most tumors of the prostate, they exhibit more than one morphology. So a primary grade is assigned to one morphology and a secondary grade is assigned to another morphology. And the both of these Gleason grade then sum together, and this is termed as Gleason score. This Gleason score is an important prognostic indicator. When there is only one pattern in whole of the specimen, then it is multiplied by 2 and this Gleason score is achieved. When there are 3 patterns, 2 patterns having highest grades are then summed together and Gleason score is achieved. So this important prognostic indicator is it denotes, when it is 6 to 7, it denotes a potentially treatable cancer that is detected on needle biopsy as a result of screening, and the Gleason score 8 to 10 shows an advanced cancer that is less likely to be cured. The low grade of the prostatic adenocarcinoma consists of back-to-back uniform-sized malignant glands. Here, some eosinophilic intraluminal crystalloids are also present that are commonly seen in cancer than in benign gland. This feature is more frequent in low-grade cancer. The lining epithelium of this cancer is single. Then the needle biopsy is showing variably sized, widely distributed malignant glands. The score is 6. Then this is highly malignant, poorly differentiated tumor. The Gleason score is 10, and the tumor is composed of sheets of malignant cells. This is Gleason score 7 photomicrograph, which is achieved by Gleason grade 3 and 4, and here there are 2 cell populations are present, and one cell population is comprising of variable glands that are separate, and these are crowded by and irregularly separated, having a poorly defined edge, while the other population that is encircling this grade 3 area is raggedly infiltrating fused glands. So these 2 cell populations that are forming Gleason grade 3 and 4 sum together, and Gleason score 7 is achieved. Another picture of adenocarcinoma prostate that is poorly differentiated, and this is exhibiting Gleason grade 5. Here no glandular structure is recognizable, only individual cells that are infiltrating, and these are marked by this black arrowhead, and these cells are assembled in rows. No glandular pattern is seen. Since its inception in 1960 by Donald Gleason, the Gleason grading system has been changing over the years. The Gleason grade 2 to 5 are not assigned, and in practice lowest Gleason score assigned is 6. However, theoretically the scale ranges from 2 to 10. Now this Gleason score 6 patient wrongly perceives that he is having a cancer in the middle of the scale, that is from 2 to 10, and he needs treatment for this cancer. And this cancer is serious, which is in fact has got a good prognosis. So a new grading group system is developed for these cases, and this prostate cancer Gleason grade group system has simplified the grading of prostate cancer, and in this score 6 category is graded as lowest grade group 1. This grade group 1 is composed of only individual discrete well-formed glands, while grade group 2 is predominantly composed of well-formed gland with a lesser component of poorly formed fuse or cribriform gland, while grade group 3 is vice versa of this grade 2, in which the poorly formed glands are predominant and lesser component of well-formed gland is present. The grade 4 is composed of only poorly formed fuse cribriform glands, or predominantly mixed of well-formed glands and lack of glands, while grade group 5 lack gland formation or has necrosis, with or without poorly formed fused cribriform glands. The imaging techniques that are used in the diagnosis and progression of this prostatic carcinoma are one is transrectal ultrasound, and this is frequently used to assess the primary tumor, and especially it is used to direct prostatic biopsies. This transrectal ultrasound is not used for staging, but no transrectal ultrasound finding consistently indicate cancer with certainty. The computed tomography for the prostate adenocarcinoma lacks sensitivity and specificity to detect extraprostatic extension, and it is inferior to MRI in visualization of lymph node, while MRI is superior to CT to detect cancer in the prostate and to assess extent of the disease. The T1 weighted MRI produce high signal in periprostatic fat, periprostatic venous plexus, perivascular tissue, lymph node and bone marrow, while T2 weighted MRI demonstrate the internal architecture of the prostate and seminal vesicles. Most cancer have a low signals, while the normal peripheral zone have a high signal. Although the technique lacks sensitivity and specificity, MRI is useful for planning of surgery and for radiation therapy also. The radionucleotide bone scan or bone scintigraphy is used to evaluate spread to osseous site. This radionucleotide bone scan are sensitive but relatively non-specific, because areas of increased uptake are not always related to metastatic disease. There are some other conditions in which there is increased uptake. These are healing fractures, arthritis, Paget disease and other conditions. The true positive bone scans are uncommon when the PSA level in the serum is less than 10 nanogram per ml, and unless the tumor is of high grade in nature. The pathological staging and the grade group system, Gleason grade group system, are used for the management of this prostatic adenocarcinoma. The pathological TNM staging system or AJCC staging system, in this the T denotes extent of the primary tumor, it is staged as PT2 when it is confined to the prostate, and T3 when extraprostatic extension is present. It is staged as T3A when this unilateral or bilateral extraprostatic extension, and it is having some microscopic invasion of the bladder neck, while it is staged as T3B when tumor invades seminal vesicle. When the tumor is fixed or invades adjacent structure other than seminal vesicle, such as external sphincter, rectum, bladder, levator muscle or pelvic wall, it is staged as PT4. The status of the regional lymph node, when it is not accessible, it is staged as NX. When no node metastasis is present, it is N0, and N1 when the metastasis in the regional lymph node is present. The metastasis is also staged as M0 when there is no distant metastasis, and M1 when distant metastasis is present. It is sub-staged as M1A when metastasis is present in distant lymph node, or M1B when bone metastasis is also present, or M1C when the metastasis is present in other sites beside these. This is Gleason score 7 photomicrograph, which is achieved by Gleason grade 3 and 4, and here there are two cell populations are present, and one cell population is comprising of variable glands that are separate, and these are crowded by and irregularly separated, having a poorly defined edge, while the other population that is encircling this grade 3 area is this is the histopathological appearance of a lymph node, a supraclavicular lymph node, that is showing the presence of metastasis from this prostate gland. The current screening program for the prevention of this prostate cancer are digital rectal examination and serum PSA level. The United States Preventive Services Task Force screening recommendations are against this PSA because they think there is a moderate or high certainty that the services has no net benefit, while American Cancer Society recommends that at the age of 50 men should talk to a doctor about the pros and cons of the testing, and they should decide if it is a right choice for them. And they also talk about the digital rectal examination and have one. Now, the clinical features of the prostatic adenocarcinoma. The localized disease can be asymptomatic or may present as a suspicious nodule on rectal examination. There can be elevation of the serum PSA level, and the urinary symptoms, they appear late in the disease progression. The clinically advanced disease present with urinary symptoms such as difficulty in starting or stopping the stream, dysuria and frequency, and also with hematuria. While the metastatic disease present with osteoblastic metastasis, that is diagnostic of this prostatic adenocarcinoma. A skeletal survey and radionucleotide bone scannings are performed for these metastatic disease. The diagnosis of the prostatic adenocarcinoma is made by transrectal needle biopsy. The prostate-specific antigen is an important marker in the diagnosis and management of the prostate carcinoma and is being used as a screening test in various parts of the world. This is secreted by prostatic epithelium and secreted in the semen. This androgen regulated serine protease is a 32 kD glycoprotein and is responsible for liquefaction of seminal coagulum that is formed after ejaculation. The normal value of PSA is 1 to 5 nanogram per ml, while it is increased more than 10 nanogram per ml in prostate cancer. This prostate specific antigen is organ specific but not cancer specific. There are other conditions in which this PSA is increased. These are BPH, prostatitis, prostate infarction, instrumentation of the prostate, and ejaculation. Many prostate cancer are indolent and clinically insignificant, and detection of these cancer may lead to overtreatment and lead to morbidity and financial cost. So some countries like UK do not recommend this PSA level as a screening test. Once the diagnosis of the cancer is established, serial testing of the PSA is helpful in monitoring the recurrence and progression of the disease. Several refinements have been made in the interpretation and estimation of the prostate specific antigen level. These are PSA density, that is the ratio between the serum PSA level and the volume of the prostate gland, and PSA velocity is the rate of change in PSA volume with time, while it is seen that there is a specific age specific change in the prostate specific volume serum level, and it is different for different ages. It is more in older age group. Then there is another term, that is free and unbound PSA, and it is the ratio of free and bound PSA in the serum. The PSA density is calculated by dividing the total serum PSA level by the estimated gland volume to estimate the PSA produced per gram of the prostate tissue, while there are the serum level of PSA is different for different age, such as it is 2.5 nanogram per ml in the age range between 40 to 49, while 3.5 nanogram per ml in 50 to 59, and 4.5 nanogram per ml for 60 to 69, and 6.5 nanogram per ml for 70 to 79 years of age. The PSA velocity is the term that is applied to a rate of change in PSA value with time. So if there is a significant rise in serum PSA level, even the latest serum level may be below the normal cutoff, it should be further investigated. The major fraction bound of the PSA is bound to alpha 1 anti-chymotrypsin, and a minor fraction of this PSA is free. So the percentage of the free PSA is achieved by dividing the free PSA by the total PSA and multiplied by 100. So free PSA is less than 25% has got a low risk of cancer, while free PSA less than 10% is concern for a cancer. There are some second line screening tests, and one of these is 4K score test. It measures 4 prostate specific kallikreins. These are total PSA, free PSA, intact PSA, and human kallikrein 2. The results are combined with clinical information in an algorithm that estimates an individual percent risk of being found to have an aggressive prostate cancer, and identify the likelihood that an individual will develop aggressive prostate cancer, defined as high-grade prostatic cancer pathology and or poor prostate cancer clinical outcome within 20 years. Another test is prostate health index. It is a blood test that estimates the risk of having prostate cancer. Combination of free PSA, total PSA, and the 2 pro PSA isoform of the free PSA combined in a formula that calculates the prostate health index. It is a better predictor of CA prostate than the total or free PSA alone. Now, treatment option for the prostate adenocarcinoma. The important step in the management of the prostate cancer is to determine the biological behavior of the tumor. So, various genomic tests are done to identify which tumor need aggressive therapy or active surveillance alone. Localized cancers that have tendency to spread locally and can potentially metastasize can be treated by surgery, that is radical prostatectomy, radiation, or hormonal manipulation with or without surgery and radiation. The survival after radical prostatectomy is more than 90% for 15 years, and this depends on pathological stage of the tumor, status of the margin of the radical prostatectomy specimen, and Gleason grade. The cases of the prostate adenocarcinoma that are inoperable due to age or other medical condition are treated by radiotherapy with either external beam radiation or by placement of radioactive shields within the prostate, that is termed brachytherapy. The metastatic carcinoma is treated by androgen deprivation therapy, orchiectomy, and LHRH synthetic analogues that induces pharmacological orchiectomy. The testosterone resistance development indicate that disease is now going to progress and it will lead to death. The mechanisms for development of resistance to testosterone are androgen receptor gene amplification, splice variant that lack the ligand binding domain, mutations in the androgen receptor that allow it to be activated by non-androgenic ligand, and mutation or epigenetic changes that activate alternate signaling pathway. Now, the prognosis of the disease. The 5-year survival rate for T1 and T2 stage of the prostatic cancer is 90%. It is 40% for stage T3, while it is about 10% for stage T4. So this discussion on prostate carcinoma give answer to our clinical scenario that we discussed in the start of this lecture, in which an 81-year-old man present to the clinic complaining of pain with urination, and he had difficulty in starting and stopping the stream of urine for the last 4 months and has recently been suffering from severe back pain. The per-rectal digital examination revealed a large palpable prostate nodule which is firm and irregularly shaped, and laboratory tests revealed increased total PSA with a decreased fraction of free PSA. So this picture is probably of prostatic carcinoma. Obviously you need further confirmation by biopsy and other tests to see the status of this disease. Just recall the pathogenesis of this disease, the involvement of diet, role of MEC protein, and TMPRSS2 repositioning of the chromosome, various genetic and epigenetic changes that are associated with prostate carcinoma, the morphological features of the prostatic carcinoma, what is PSA, the Gleason grading system, the clinical presentation of prostatic carcinoma with various type of clinical presentation, predicting the involvement of the area and the various treatment modalities that are available for this prostatic carcinoma.